Professor of Anesthesia and Intensive Care, and the head of the liver transplant and anesthesia and surgical intensive care unit. I am so happy to be tonight in between those talented people and leading the project of liver transplant in Al Mansoura University. Professor Amr Yassin is the head of the unit, and Dr. Mahmoud Al-Murshidi, lecturer of anesthesia and intensive care, and Dr. Mustafa Abdul Khalik, lecturer of anesthesia and intensive care, Dr. Mu'taz Amara, lecturer of anesthesia and intensive care, Dr. Mahmoud Siddiq, lecturer of anesthesia and intensive care. We are going to join today. My relationship to Al Mansoura has been built up a long time ago with my excellent colleague, Dr. Muhammad Makarita. He's the head of the pain medicine, and we start now to another era with Al Mansoura University. Dr. Amr Yassin is the chair of the liver transplant, and all yours now. Thank you. Dr. Amr.
Assalamu alaikum. I have the honor and the pleasure to be with you today, and I want to express my great appreciation to those who are creative and created this way of communication to fill up the gap of the science communication during the COVID-19 crisis. Thank you very much for the organizers for this act. I'm honored to present for the next 25 minutes probably, the preoperative evaluation for living donor liver transplant recipients. If there is anyone from outside Egypt, in Egypt you are obligated to do living donation, although we have the law approved by the parliament for cadaveric transplant 10 years ago, but it is not yet enforced. This is our lovely city, Mansoura, our hospital, the Gastroenterology Surgical Center. This was the start of our anesthesia team with my fellow and the intimate friend, Dr. Walid Sarraf, who is in Saudi Arabia right now. It was 2004. This is the second case of liver transplantation in Mansoura. This is our team 2017, and this is today, because actually it is surprisingly an accident to have a special case of liver transplantation today. So we are broadcasting from the hospital now. Lyndon Johnson has said once, doing what's right is not hard. Actually, knowing what's right is the hard part of any job. When you face a patient for liver transplantation, you have to either accept it, reject, or accept conditionally to correct the patient condition and then proceed or not proceed into the operation. Because there is what's known as futile treatment. Futile treatment means that treatment then extends the life of the patient without improving the quality, and even you may have what's called futile outcome. You have a 3 months or hospital mortality, which we don't hope for our patients. So the aim of the pre-operative assessment is to determine the futility index, whether this patient is going to benefit or not from the operation. So sometimes the patient is too ill, and sometimes the patient is too bad for the liver transplantation. The surgeons usually use what's known as MELD score. So they assume that if you have a MELD score less than 15, that's good, and more than 15, that's risky. Actually, this is a very concise view, because liver transplantation outcome is usually affected by the MELD score, but also the severity of liver disease, the acute conditions, as well as the chronic comorbidities the patient might have. Several guidelines have determined the risk factors that affect the short-term mortality and long-term mortality. The short-term survival is affected mainly by renal impairment, cardiovascular diseases, malnutrition, and the frailty or poor general condition of the patient, while the long-term survival is affected mainly by the cardiovascular risk. So it's very important to determine if the patient has one or more of these risks before accepting him in your transplant program. We all know what are the indications who are indicated for liver transplant, but we should also know who are contraindicated for liver transplant, which is more important. Those having severe cardiac or pulmonary disease are contraindication for liver transplantation. To assess the patient, we will have to examine the following systems: the kidney, the cardiovascular system, the pulmonary system, his nutritional status, his coagulation profile, as well as we should do proper infection management and control. For the kidney, it's surprising. What is the prevalence of renal impairment in cirrhotic non-hospitalized patients? It's about 20% have a renal problem. This will be increased up to 50% in those with advanced cirrhosis and ascites, which represents the majority of our patients in Egypt. The mortality is 6-fold in those patients compared to the same cohort without cirrhosis. However, there is an old misconception that cirrhosis plus increased serum creatinine equals hepatorenal syndrome, which is not true. Cirrhosis plus increased serum creatinine might be volume responsive, pre-renal, might be volume non-responsive, still pre-renal, and this is the actual hepatorenal syndrome, might be intrinsic renal disease, ATN, coexisting disease such as amyloidosis, or post-renal causes. Surprisingly also, the non-hepatorenal factors represents more than 95% of the patients. Hepatorenal syndrome has been defined more than 70 years ago, and the definition and the defining criteria were stated 40 years ago and still solid till now. So the patient must have a serum creat more than 1.5 without shock, without being hypovolemic, without having any nephrotoxic drugs currently or recently, and there's no parenchymal kidney injury. By this way, you can define hepatorenal syndrome simply. Hepatorenal syndrome type 1, which is less common, fortunately, but it's very aggressive with rapid increase in the serum creat within weeks. It has a poor prognosis and mortality is usually imminent in those patients, while in type 2, which is the most frequent, the elevation of serum creat is gradual, and you have a chance for treating or correcting the condition for these patients. There are another 2 uncommon types of hepatorenal syndrome. They are a little bit recent. Hepatorenal syndrome on top of chronic renal disease, which is now known as type 3 hepatorenal syndrome, and hepatorenal syndrome on top of acute liver cirrhosis or acute liver failure, which is known as defined now type 4 hepatorenal syndrome. What about the treatment of hepatorenal syndrome? Actually, it's not a treatment, because there is no treatment of hepatorenal syndrome apart from liver transplantation, which is the only treatment. But these are correcting factors. You can use these measures to bridge the patient until you have a safe liver transplantation operation. So the only definitive treatment of hepatorenal syndrome is liver transplantation. But when to do it, there is a protocol for that. If you have type 3, that means that you have hepatorenal syndrome on top of chronic kidney disease, you have to do simultaneous liver and kidney transplant. If you have type 1 or 4, that means that the patient is in acute liver failure or type 1 hepatorenal syndrome, the patient needs only liver transplantation. While if you have type 2, you can proceed into liver transplantation and see if the kidney tolerated after the operation, or you can plan for sequential liver transplantation and kidney, starting with the liver, then followed by the kidney transplantation. What about the cardiovascular risk? Usually, the risk is mainly seeking for asymptomatic coronary artery disease patient. We do ECG and transthoracic echo. However, those cannot detect the asymptomatic coronary artery disease patient or ischemic heart disease patient. Meanwhile, another misconception in the liver transplantation is that cirrhotic patients are protected against coronary artery disease. This is totally not true. And those patients have the same risk factor and the same incidence of occult occlusions of the coronary artery as the other cohorts of patients. Also, there are specific cardiovascular disorders related mainly to cirrhosis. So there should be another modalities for assessing those patients. Non-invasive ischemic testing, including the stress echo, stress ECG, isotope scanning, and coronary angiography. However, it's now proved until now that the dobutamine stress echocardiography is a predominantly better way for assessing the cardiovascular system or cardiopulmonary system in those patients. Although coronary angiography is giving good results, yet the stress echocardiography will add value of detecting what's known as left ventricular outflow tract obstruction, which is common up to 40% in those patients, and also detect subocardiomyopathy or the stress cardiomyopathy, which is present in 10% of these patients. So now the dobutamine stress echo is considered as an invaluable tool for assessing the patients preoperatively, and it is a routine in our center in Mansoura. What about patients having coronary artery disease prior to transplantation? Best results and 1-year survival are better if you are stenting those patients or treating those patients before liver transplantation. Of course, there is a risk of bleeding and the risk of renal impairment from the excessive use of the dye during complex procedures. Yet, if you didn't do this, this is what will you have with your patients. This is a patient of intraoperative cardiac arrest. Of course, alhamdulillah, we managed this patient and he survived. And later on, he was stented. For the pulmonary system assessment, we have 4 major problems common in the liver, patient with liver transplantation, and can be detected preoperatively: hepatorenal syndrome, portopulmonary hypertension, hepatic hydrothorax, and pulmonary function testing. First, the hepatopulmonary syndrome, it's a little bit common, from 4 to 32% in the literature, and there is no cure, there is no treatment for this syndrome. There should be pulmonary portal hypertension, arterial hypoxemia, and intrapulmonary vascular dilatation, which is not treatable. What's our role? Our role is to identify and determine whether this patient has what's known as reversibility or not. If the patient is reversible, this means that the vascular anomalies can be closed after liver transplantation. These patients should proceed into liver transplantation. Otherwise, if this is irreversible, you cannot proceed into liver transplantation because still the pathology will persist after transplantation. We depend on the clinical hypoxia and orthodoxia test, measuring the PO2 while the patient is standing and the patient is lying flat, imaging, and particularly contrast echocardiography using bubble test, which is very simple, are highly diagnostic for this disease. Second, which is very common also, up to 16%, overall 8%, is portopulmonary hypertension. We had the privilege in Mansoura to have an international publication about this issue, and our percentage in Mansoura is 2.17% of the patients, of our patients have portopulmonary hypertension. It can be detected by several methods like the ECG, but it is not specific, the transthoracic echocardiography, and confirmation is always done by the pulmonary artery catheter. What about the transthoracic echocardiography? The problem is that it may sometimes overestimate or a little bit underestimate the pulmonary artery pressure. This is the case. As you see, the pulmonary artery pressure is 53 mean millimeter mercury. This case was diagnosed with normal pulmonary artery pressure with the transthoracic echo preoperatively, and in the operation, while we, after induction, introduced the pulmonary artery catheter, was faced with this problem, and the patient was awakened and the operation cancelled, and died 40 days after the operation from heart failure. So, portopulmonary hypertension is a very important issue. You have to determine in the preoperative period whether to transplant or not to transplant. We have a mild, moderate, and severe degrees based on the mean pulmonary artery pressure. The mild, between 25 and 35, and in this case, proceed into transplantation, no problem. The moderate is between 35 and 45, and in this part exactly, we are going to assess the pulmonary vascular resistance. It will give us a clue whether to accept this moderate patient or give him a trial for treatment. And for the severe, it is contraindication for liver transplantation when the mean pulmonary artery pressure is more than 45. There is what's called as reversibility. In the moderate cases, if the pulmonary vascular resistance is more than 40, this means that the patient, 400, sorry, this means that the patient usually is irreversible, and the main pathology is due to arterial hypertension, arterial proliferation. So this patient usually irreversible, and you should reject the transplantation. Hepatic hydrothorax or pleural effusion is very common in liver transplant recipients, particularly those with end-stage liver disease, not cancer-related. Usually on the right side, more than 90% on the right side, and usually the sterile effusion. You will do CT to assess if there is underlying collapse or no collapse. If there is no collapse, proceed to the operation. If there is collapse, you will decide whether to drain or not to drain. And if you think about drainage, we should also determine if you are going to drain preoperatively, which is not a good option, or intraoperatively. Usually, lung recruitment occurs with the positive pressure ventilation, so it's better to wait for the intraoperative period to assess your oxygenation after the patient is anesthetized, and determine if you have to do drainage or not. It's better, of course, not to do drainage so long as you can oxygenate the patient with the usual 40% O2. Pulmonary function testing. There is many confounding factors that affect the results of the pulmonary functioning, like tense ascites, interstitial pulmonary edema, pleural effusion, muscle wasting, intrapulmonary shunting. These factors will result in either obstructive ventilatory pattern or restrictive ventilatory pattern. However, the commonest in liver transplant patients in stage liver disease is the combined ventilatory pattern, where we have obstructive and restrictive pattern at the same time due to several factors. In this condition also, especially for patients with end-stage liver disease, you have to assess the reversibility. Again, remove the factors that affect the restrictive pattern, like the tense ascites, for example, give diuretics for the pulmonary edema, give bronchodilators for the obstructive ventilatory pattern, and assess after 2 weeks. If the condition improved, you can proceed into liver transplantation. Nutritional management. This is the nutritional management of our physicians. Usually we transplant 4 cases in Ramadan, and this is one of our collective breakfast in last Ramadan, where the team have breakfast in the operating theater, since we usually end after that time. It seems a happy picture, but if you seek in the literature for help about the nutritional management of liver transplant patients, you will not find a lot. Many of the publications are talking about the fact that there is no intervention is likely to be beneficial in managing nutritional deficiency in liver transplant patient. Even assessing the nutritional status of those patients are problematic. You have to use the history, the anthropometric measures, the laboratory changes. The best is the subjective global assessment is now our preferred technique, and we use it in Mansoura University liver transplant program. As a contraindication, BMI more than 40 is a relative contraindication for liver transplantation. Actually, we didn't face this problem in more than 750 patients, because this is usually our Egyptian patient, severely malnourished and thin due to anorexia, nausea and vomiting, early satiety, malabsorption, and altered metabolism. Is this prevalent in cirrhotic patients? Yes, more than 70 to 90% from several studies in the cirrhotic patients have malnutrition. In the liver transplant cohort, especially for end-stage liver disease, not for tumors, it's nearly 100%. It can affect the outcome greatly. It can increase the rate of transplantation complications, increase intraoperative transfusion requirement, increase time of ventilation, hospital stay, cost, and high incidence of graft failure, and even can increase the mortality and the reduce the survival of those patients. In a study on 150 patients, it was found that survival was improved to 88% from 54% just by nourishing the patient versus malnourished group. However, correcting the malnourishment of those patients, particularly the severe, is not a good job. You can't achieve it mostly. And the literature mentioned that there is no clear evidence that any treatment will, whatever the kind, will improve the outcome of liver transplant if they give preoperative nutrition to those patients. So if you have a mild or moderate malnutrition, you can have a try and you give the patient a chance for nutritional correction before the operation. But if you have a severe cachectic malnourished patient, mostly do not go into the operation, because this patient will not tolerate, if tolerated the operation, they will not tolerate the hectic postoperative period. Coagulation assessment, another common misconcept. Cirrhosis means bleeding. Please, cirrhosis doesn't mean bleeding. The components of coagulopathy in cirrhotic patients includes bleeding, the contrast, which is accelerated intraoperative intravascular clotting, and hyperfibrinolysis. All these components are present in the cirrhotic patient. Whatever component of them will be predominant of this patient, it will be clinically presented. To diagnose, you have to take the history, symptoms and signs of coagulopathies, whether the hypercoagulable state or hypocoagulable states, and of course investigations that includes all aspects of the clotting system. However, not all aspects can be measured in the lab. For example, the platelet functionality, the cellular component of coagulation, and the interaction between the cellular component and the protein component. So now the world depends on the elastometric studies, where you can study the dynamics of the blood clotting in vitro in a real life manner, and you will have a diagram illustrating what is the main problem in the coagulation of this patient. Usually we don't see such a curve, which is a good curve in our transplant patient. Usually this is the kind of curves we have because the Egyptian patient is always late in coming for seeking for medical advice. So our patients are usually in a state of hypocoagulation. The rotem can detect the coagulopathies efficiently, including the coagulation component balance, the platelet function, and the cellular elements and interaction. As you see, they are all dynamic components that cannot be measured in the lab using a tube. And there is a correlation between the rotem elastometric studies or the elastometric studies analysis and the standard hemostatic parameters in liver transplantation. Can this rotem or elastometric studies predict intraoperative blood product? Yes, it can predict intraoperative blood requirements. It's very sensitive, so we usually do it preoperatively to assess the liability of these patients to have a bleeding intraoperatively. And I'm delighted to present this study because it's coming from our friend Dr. Amr Yassin and his marvelous team in the Monofia Liver Institute, who are very proud of this publication. Lastly, and not the least, is the infection management and infection control in patients of liver transplantation. Actually, patients for liver transplantation should be screened at the following times. Screened, of course, for infection. For the first time on enrollment, all patients should be screened usually for viral infection and chest X-ray for signs of all TB. Second, on listing, when they are listed in our program, all patients should be again screened for mycobacterium, dental chest X-ray done, CMV, Epstein-Barr virus, and on admission to the hospital, specific subset like seeking for the gram-negative organisms, seeking for the multi-drug resistant colonization in those patients. However, is pre-transplantation non-specific antibiotic prophylaxis safe? Should you give your patients preoperative antibiotic prophylactic treatment haphazardly? All the studies has determined that broad-spectrum antibiotics preoperatively are very hazardous to those patients and to your intensive care. The risk of broadening the spectrum of non-specific prophylaxis will increase the Clostridium difficile infection in the patient and in the ICU. It will have a financial burden and it will produce antibiotic resistance in your facility. Is the pre-transplant specific antibiotic prophylaxis for colonization effective? What we actually have is that we have smears taken for the patient for culture. Sometimes there is colonization of a specific strain of bacteria. What happens if you give a treatment to this specific strain of bacteria, which is actually a colonization before transplantation? Actually, nothing. Until January 2019, there is no studies evaluating whether these will be effective or not in reducing the post-operative infection transplant. So it's worthless to do decolonization of the patient before liver transplantation. Lastly, TB, which is a major problem nowadays because it's reactivated again in the community. You may have a latent TB or active TB. And in the active TB, you may have it in the pre-transplant period or in the post-transplant period. Of course, if you have active in the post-transplant, this means it was latent and activated after the operation by the immune suppression. For the latent TB, it's surprisingly worldwide that 1/3 of the world all the patients for TB. This is an active screening. This means that all patients should be asked for treatment. Our previous hospitalization for TB should be examined for symptoms and signs of pulmonary and extrapulmonary TB and should have a battery of investigations, including radiology, quantiferon, and microbiological testing. If you have a patient with latent TB prior to liver transplantation, you have one of 3 protocols. The main protocol is using isoniazid only daily for 9 months if you have time. Usually, it is not available in the living donor. You don't have to wait 9 months to transplant the patient. So in this situation, you can start because it is effective, but it's very toxic. You can start pre-transplant and complete the 9 months post-transplantation. The second protocol, which is more stronger, isoniazid plus rifampicin, it usually takes for only 12 weeks, but this cannot be started post-transplantation because of the major conflict or drug interaction between the calcineurin inhibitors and the rifampicin. And of course, the third protocol is rifampicin only, should be reserved to milder cases. If you have an active TB, this means the mortality will be high and should be treated. It may be post-transplant, and as I said, it will be a latent and activated, or it may be very obvious like this person, and it is diagnosed as a pre-transplant problem. If you diagnose TB pre-transplantation, which is mostly usually more than 70% extrapulmonary, you should proceed into the 4-drug regimen protocol for 4 months, isoniazid, rifampicin, barinzamide and isambitol for 4 months, then downgrade the protocol into isoionazide and rifampin only for another 4 months if you have time. If the patient has a major problem in the liver functions and cannot tolerate, fluoroquinolones might be the alternative, just only in poor hepatic functions. To summarize, we should decide if the patient is fit for transplantation or not. Pre-transplantation decisions markedly impact the post-transplantation outcomes, and it is never a single risk in liver transplant patients, so do not miss any. Pre-transplantation assessments will drive your plan for the intraoperative management of those patients, and sometimes, for the sake of the patient, it is better to say no. Again, I have the privilege to be with you today, and thank you very much for your attendance.
Thank you very much, Prof Amr Yassin, for this very informative lecture. It is absolutely fantastic to have you today, and I'm sure a lot of people tonight, use this lecture as a review.